Hi everyone, my name is Yiye and I am an assistant professor in the Department of Population Health Sciences and Emergency Medicine at Weill Cornell Medicine. And my talk today is about examining patterns of computerized physician order entry in emergency and inpatient heart failure management. Here is my disclosure and the outline of the talk today. So the study that I'm going to present today is motivated by the question of whether we can discover clinically relevant patterns from data, as in can we facilitate the evidence discovery process from large enough data such as electronic health records to identify treatment variations, common practices, or even optimal practices that may be hypothesis generating and, more importantly, informing our understanding of the current healthcare landscape. So this line of work has been active in at least the last 20 years, if not more, with these previous work, including my own. So these work use statistical modeling, machine learning, process mining, visual analytics methods to identify patterns from data. And oftentimes, we have started with finding computational subtypes within a population so that we can find subtype-specific patterns to investigate. So for example, in my own work of deriving data-driven order sets and data-driven clinical pathways, I have often used clustering algorithms to discover underlying subgroups first, then try to mine patterns within each cluster that may be used to develop order sets and clinical pathways from data. And one limitation in the methodology that I have realized in using regular clustering algorithm is that the algorithm typically is unsupervised, such as k-means and hierarchical clustering. These are unsupervised clustering algorithm. Whereas in healthcare, there's often a risk to prevent or outcome of interest to improve. So applying regular clustering algorithm to a population did not guarantee that we're separating the population according to the risk or the outcome of interest, especially in a heterogeneous population with heavy comorbidity burden. For example, in heart failure, there are a lot of factors that drive variations in patient outcomes as well as treatment patterns. And heart failure is a syndrome that impacts nearly 6 million Americans. More than 80% of individuals suffer from 3 or more comorbidities. So the complexity in treating heart failure due to frequent comorbidity and the lack of guidelines that incorporate heterogeneity present challenges in the discovery of patient strata to assist with clinical decision making. Motivated by these clinical needs and the methodology limitations, in this work we tried to develop a methodology called deep significance clustering, or DICE as we call it, in addressing some of the limitations that I just mentioned. So intended to stratify a population based on both similarity and risk level for an outcome of interest, DICE is an end-to-end framework containing representation learning, clustering, and classification components. The goal of DICE is to identify representations that generate clusters that are similar with respect to input features and outcomes, such that the resulting clusters can be used to develop risk stratification for patients needing similar interventions. The novelty and feasibility of DICE in generating these outcome-driven clusters originate from the use of a combined objective function, including a constraint that requires statistically different outcome distribution across clusters. So this framework enforces backpropagation through the representation, clustering, and outcome prediction components, which make up DICE as a framework. And the last step of DICE performs a neural architecture search designed with an alternative grid search strategy over the number of clusters and representation dimension size to heuristically optimize outcome prediction. So we can stratify patients with DICE, and the completed or the trained clusters can be used to classify unseen patients into risk level specific clusters in a multi-class classification to allow in real implementation new patients to be assigned into risk level specific subgroups, treatment protocols, or clinical pathways. And DICE is customized to medicine by considering statistical significance, a concept well known to medical researchers and clinicians, into a machine learning framework. Previous work on risk stratification and subtyping have commonly conducted post-hoc analysis on variable significance, whereas in our case, as we'll show you later, DICE directly incorporates the significance as one of the as a constraint. So for evaluation and for experiment, we applied DICE on a real-world electronic health records from New York Presbyterian Hospital, Weill Cornell Medicine, this data set includes 1,585 patients who were treated, admitted to the hospital for heart failure, and the outcome of interest was discharge to home, which affected nearly 37% of the patients. So the EHR data were extracted from 2 hospitals of New York Presbyterian Weill Cornell Medical Center, and the electronic health records variable extracted include information on sociodemographics, vital signs, diagnoses, therapeutic orders, medication prescriptions, laboratory test orders, and test results, as well as census tract level social determinants of health. The sociodemographic information included age, gender, race, marital status, preferred language, as well as payer. Diagnoses were used in terms of ICD-9 and 10 codes, and we also defined heart failure using ICD-9 and 10 codes. And the data includes patients from years 2014 to 2018 who were treated in the inpatient medicine services only. We compared DICE with baseline methods, including PCA autoencoder for representation learning, and clustering of using k-means clustering only. So the difference between these baseline methods, so we apply 3 types of baseline methods. First one is using PCA to reduce dimension as a form of representation learning, followed by k-means clustering. The second one used autoencoder for representation learning, followed by k-means clustering. And the third one trained autoencoder in conjunction with prediction using logistic regression, so that the autoencoder were informed in a way by the outcome prediction. And then the trained autoencoders was then applied into k-means clustering for clustering. None of these baseline methods included the constraint that DICE has on enforcing statistical significance across clusters in terms of their outcome ratio. And I also want to point out that specifically regarding the focus of outcome drivenness, there are also other relevant work here from 2019 to 2020, which includes the temporal phenotyping using deep predictive clustering of disease progression, as well as work, multiple actually pieces of work from IBM on outcome-driven clustering, which where I'm citing one here. So want to show you the clustering metrics comparing DICE with the three baseline methods that we were able to compare. So as you can see, DICE in terms of the clustering metrics of silhouette, Kalinsky-Haber-Raz index, Davies-Bowden index, DICE has a superior performance, higher silhouette score, higher Kalinsky, Haber-Raz, and lower Davies-Bowden, showing a better cluster purity. And we also had a focus on making sure that the clusters had different or had a trend in terms of the incidence of outcome across clusters. So we calculated the risk ratio between each cluster and the cluster with the lowest incidence as the reference group. So here you can see that from the four clusters that were generated by DICE, the risk ratio between each cluster and the reference is 6.77, 3.32, and 2.91. I want to point out here that in this baseline model where we trained autoencoder with logistic regression and then fed the representation from that to k-means, also had a pretty good risk ratio. But combining with cluster purity, I think that DICE did pretty well in terms of clustering metrics. And here is a visualization of DICE comparing with the other baseline methods, PCA, autoencoder plus k-means, autoencoder logistic regression plus k-means. So we can see that DICE clearly separates the population. And as I mentioned, in the four clusters that were generated by DICE, the first cluster had nearly 80% of the outcome discharge home, followed by 38%, nearly 30%, and 8.6%. Whereas this PCA, for example, we can see that it is not outcome driven, as in there isn't too much difference in terms of the cluster's incidence of the outcomes. And then I also wanted to show you the outcome drivenness of the representation that DICE was able to learn. So looking at the AUC, we can see that AUC, positive predictive value, negative predictive value are collectively higher in DICE. And we also looked at the fairness across racial subgroups, where the AUC for race unknown, Asian, other, Black, and white are relatively similar, ranging from 0.78 to 0.86. And then here is the cluster characteristics in terms of demographics, the ratio of female patients, comorbidity, and the use of medication. So we're looking at an upward trend in terms of having more patients that are getting discharged home, and looking at the medications and the diagnoses, we can also see some upward trend or downward trend across categories. So to sum up in the interest of time, our analysis found 4 clusters of patients based on both the similarity of order types and the sequence of placement, and we were able to identify statistically significant association between the cluster memberships and the outcome of interest, which is discharge home, and we also identified characteristics that were significantly different across clusters, including comorbidity burden, the orders or the medications that were placed, and some demographics. Now, there's an important limitation to this work that we're still currently trying to address, which is that we're trying to assess if there's a way to determine the appropriate of the orders that were given to the patients, as in were they adherent to the guidelines, and if different orders were placed, could they clinically be considered substitute? So there's a lot of work that needs to be done in terms of clinical relevance of the work that we'd like to pursue. In terms of future work related to the methodology, through this demonstration and experiment with DICE, we think that the flexibility of the DICE framework allows different kinds of algorithm, even though here we used autoencoder, k-means clustering, but potentially DICE can be constructed with other algorithms for representation, for clustering as well. And if we include images and nodes, we can also look at different kinds of model, for example, CNN for images, transformers for nodes, and so on. And lastly, this work only considered significance in terms of the p-values, but other concepts in statistics may be explored to better ensure outcome separation across clusters and more focus on the outcome-drivenness of the clusters. So with that, I'd like to end and thank all my co-authors in the work from Weill Cornell, Columbia, Vanderbilt, and New York University. And thank you for your time. If you have any questions, here is my email. Thank you.